Predictors of Stigma and the Effects of Stigma. But before that, I'd like to introduce myself. My name is Dr. Winnie Nyanya, working with the NASCOP, the National AIDS and STI Control Program, and I am a technical advisor in pediatrics and adolescents. So today I'll be your moderator for the session today. I'd want us to discuss a bit on what HIV stigma is. HIV stigma is a negative attitudes and beliefs about people with HIV. It is a prejudice that comes with labeling an individual as part of a group that is believed to be socially unacceptable. We have seen stigma in several situations, especially among HIV populations when it comes to the key populations, and also self-stigma among adolescents and youth. Therefore, this has affected different populations of people living with HIV. We want to differentiate stigma from discrimination, which refers to behaviors that results from those attitudes and beliefs that are caused through stigma. So HIV discrimination is the act of treating people living with HIV different from those without HIV. And we have several scenarios where discrimination happens in the health sector, in the community, in the facility, and even at home, and also in terms of labeling people living with HIV with different names. So when you talk about how stigma affects a person living with HIV, what are the effects that we're looking at? Stigma and discrimination can affect the well-being and mental health of people living with HIV. They internalize this stigma and they experience something called a negative self-image, and they fear that they will be discriminated against or judged unfairly when their HIV status is revealed. So most of the time we see internalized stigma or self-stigma, even among our adolescents and youth today. We see a lot of that, and this is something that we can do. There's something that we can do to really address this stigma. Looking at the Kenya AIDS Strategic Framework, we know that one of the targets and the objectives in the Kenya AIDS Strategic Framework is to reduce stigma from 45%, this is a figure that was gotten in 2014, to less than 25% by 2025. So as a national program, we know there's a lot of work that needs to be done to really address this stigma. Several initiatives have been brought about to help addressing stigma and kicking out stigma, especially among the youth. And most of you are aware of the Maisha County Leagues, which was one way that would help in reducing stigma among the youth through football leagues that would really enhance HIV testing, knowledge of HIV status, and just having us talk about HIV more so that we can be able to demystify any myths and misconceptions that are coming through HIV, the notions that we have in HIV among the community. So for NASCOP and the National HIV Program, we are aware of the gaps and that come about programming for interventions to address stigma. And we are working towards ensuring that we are able at the facility and community level to reduce stigma and discrimination. So some of the, as we talked about stigma happening in the adolescents, looking at the areas and points at which we experience stigma for, we see adolescents experiencing stigma is mostly during transition. When adolescents are transitioning from pediatric to adolescent care, there's the issue of disclosure. If it is not done well or not done at all, it can lead to self-stigma among the adolescents. And also when they're transitioning from primary school to high school, which most of the time in Kenyan settings is in boarding schools, we see that they experience stigma and discrimination because they have to go to school with their medication. And also when there's a death in the family and any transition, that would then mean that if the parents probably were known to be living with HIV, then the adolescents and youth or the children will then be stigmatized because of that. And we've seen also situations where we have adolescents who have stigma because of the fact that probably they're the only child in the family who are living with HIV, and some others are HIV negative. So we've seen situations where this stigma happens in the community and in the family. So as a national program, we have priorities that would help us be able to address this stigma and discrimination. And one of the things that we really look forward to doing, and we are currently doing, probably we would want to continue doing at scale, is the psychosocial support groups that we've been having for adolescents. And these are peer-led that would help in ensuring that adolescents have the support they need to deal with the challenges that come with stigma or living with HIV, and also just improving the treatment literacy. And the literacy for adolescents and their caregivers on HIV, and giving the adolescents and youth life skills so that they can be able to have self-efficacy and deal with the stigma and discrimination in the community. And also looking at other ways of working with other stakeholders, including the education sector. One of the feedback we got from the youth is that the curriculum they have in schools and in colleges is outdated, and it can also contribute to stigma because of, for one, the kind of pictures that are being shown in terms of people living with HIV, how they look, and giving that kind of idea that people living with HIV are sick and should be avoided. So therefore, working also on just ensuring that we revise this, we are able to give the right information out there for everyone to be aware of what HIV is and dispel the myths and misconceptions. So in a nutshell, that's what I can say about HIV-related stigma, especially among the youth. And so moving on swiftly, I would want to introduce our speaker for the day. That is Dr. Cyrus Mugo. He is the Senior Research Scientist at Kenyatta National Hospital, Department of Medical Research. His research over the last 10 years has focused on the HIV care cascade for children and adolescents. This includes pediatric index testing, early start of treatment for infants, neurodevelopment for children living with HIV, HIV self-testing by adolescents and youth in the community, training of providers to offer adolescent-friendly HIV services, and developing tools for HIV status disclosure and transition from adolescent to adult care. He is the principal investigator for a series of studies looking at self-disclosure of one's HIV status by adolescents and youth and young people living with HIV, developing implementation strategies for mental health screening and management in HIV clinics, and optimizing viral load monitoring for children and adolescents in care. Today, he will present the work on HIV stigma from the DISC study conducted in Western Kenya. Welcome, Dr. Mugo.
Thanks so much, Winnie, for the great introduction, and very challenged to add some value in the work that NASCOP is already doing in this field. Big thanks to the DISC team for allowing us to work with you, use your data to address some of the questions that we have on HIV stigma. I hope you can hear me well. Maybe Dr. Nyanya, you can signal?
Yes, we can hear you and we can see your slides.
Great, thank you. So I will proceed. You've already mentioned this definition, and I'm very excited that hopefully this is how it's looked at in the program. Stigma being a socially damaging phenomena where groups are identified with certain characteristics or behaviors, and they are discredited for it and considered socially undesirable, unfit, or lacking value. And some of the things that we know that stigma does is with an immediate experience of loss of social standing or status, you suffer stereotyping, and something that has not been talked about a lot, now coming up in literature, is the loss of power in relationships, and defining the power dynamics in relationships, whether it's family or professional, or even with institutions, so institutional relationships. There's that loss of power due to stigma, and HIV is the study case when it comes to this loss of power. And as you mentioned, discrimination is part of the continuum of stigma, but could be considered the endpoint of stigma. When we start talking about types of stigma, we will talk about something we call experienced or personalized stigma, and that could be, part of the discrimination process. But we will not call it discrimination today. Today we will stick with the definition of stigma. So to study stigma, one of the things that we found, especially when we are developing interventions, thinking about interventions that could act as anti-stigma, catalyze anti-stigma attitudes, is we've got to think about stigma in levels. There is the intrapersonal level, which is basically, an individual or personal beliefs and what they've internalized, what they believe, what they've seen, that contributes to how they view people living with HIV or themselves if they're living with HIV. And then we've got the interpersonal, which is a relationship at a very close level. And here we're talking about relationships with family and friends, and the attitudes that you develop with that kind of relationship with people living with HIV. Then we've got the community, and this your neighborhood, talking about your community leaders, your community groups. And then we've got the institutional, and there's a bit of an overlap between the institutional and community levels. With the community, you think of a little less formal structures. And so even when you're thinking about community interventions for stigma, you're thinking about less formal structures and more, it goes much closer in the interpersonal relationships, but at the community level. With institutional, we are thinking about schools. The health-related stigma is a big topic. Employment, and this has been litigated quite a bit. When you're talking about disclosure of HIV test results, employers asking for HIV tests and so on. So we've got a big topic we can discuss about institutional level stigma. And then we've got the structural level. And here we're talking about, at maybe a country level, we're talking about government policies, employment policies. What are the anti-discrimination laws that we're dealing with as a country? So this, using the socio-ecological model could be one way to study stigma. But there's another way to look at it, and guided by the Health Stigma and Discrimination Framework. This is a very old and very well-tested framework that looks at stigma, basically health-related. And this can go across many disease and conditions and behaviors. It has been studied for, many chronic illnesses, has been studied for behavior, sexual orientation, and gender orientations. And what we are seeing here is an adaptation of what the group Turan and group did in 2017, thinking of 4 stigma types, making up the full spectrum of stigma. And that is experienced stigma, or what we call personalized stigma, or perceived. Then we've got the perceived community stigma or public attitudes. And then we've got internalized stigma, beliefs at an individual level, and anticipated stigma, disclosure concerns. And what the Health Stigma and Discrimination Framework tries to do is link the different domains, the different types of stigma to outcomes, and give hypotheses that can now be tested. Some of them have already been established in adult populations. Like experience stigma has a big impact on physical health and also mental health, for example. Internalized stigma has been shown to affect mental health and healthcare behaviors, especially treatment adherence. So what are the research gaps? So few studies globally, and even fewer, it's very counterintuitive that very few studies have actually been conducted in sub-Saharan Africa. One, to study what are the things that predict or co-occur with HIV stigma, and we'll see why this is important. And then the second point, what are the things, how does stigma affect health, basically? So a lot of the studies have been conducted outside of our population, and even so much fewer have been conducted among adolescents and youth. Then the second item is very few studies have rigorously evaluated stigma interventions, and especially among youth. And this is the work we are now carrying out, trying to establish them. And that is why this preliminary work is important to us. So for this study, what we were trying to accomplish is one, estimate prevalence of HIV stigma and the different mechanisms or types. You'll hear me interchange the word stigma mechanisms, stigma types, stigma domains to mean the four types that we talked about among youth living with HIV. Then the second aim was to determine the predictors of HIV stigma and also the specific stigma mechanisms or types. And then lastly, to determine the effect of HIV stigma and the specific mechanisms on mental health and HIV treatment outcomes among youth living with HIV. So basically, we will be attempting to disapprove or approve the hypothesis driven by the health stigma and discrimination framework. Our population was from the DISC study. This was a longitudinal cohort of adolescents and youth ages 10 to 24, carried out in 9 sites in Western Kenya between 2019. So we used the data between 2019 and 2020. And this is the data comprised of survey data and also routine clinic data abstracted from the electronic medical records. Our current analysis will only look at the youth, or what we call the youth population, 15 to 24 years. We excluded the younger population due to several things. One, many of them had not been disclosed to. It was a small population when you look at the whole age range that was enrolled. And we wanted to present a message that can be coherent for programming. So the 15 to 24 seemed like a group that you can do programming for, similar programming for. The 10 to 14 will have to do separate programming for them. And we also wanted only those who had a baseline survey done. So coming to our measures, how did we measure stigma? We had several variables. So stigma was measured using the 10-item youth HIV stigma scale that was, the RIGHT 2017. And it has 4 domains. So each one of the 10 questions is assessed on a 5-item Likert scale that goes, from strongly disagree at 1 to strongly disagree at 1 and strongly agree at 5. So the specific types, or what we call the domains or the mechanisms, the 4 of them were assessed. Experience stigma was assessed using 3 questions. Internalized stigma was assessed using 3 questions too. Anticipated stigma using 2 questions, and perceived community stigma using 2 questions. So we had an overall stigma score, a continuous score, and this was only computed for those youth who answered the 10 questions in the scale. So there are those who answered maybe 9 or 8, and we did not give them an overall stigma score. And this score was presented as a continuous variable with a score ranging between 10 and 50. So looking at the specific domain scores or the types, so we also included only those youth who completed all the questions in that domain. So for example, for you to get an experience stigma score, which was between 5 and 15. You should have completed the 3 questions that assessed it. Internalized stigma had a score of 5 to 15, 3 questions again. Anticipated stigma, 2 to 10, and then the perceived community stigma, 2 to 10. So we also created some binary variables for their specific domain scores. And so to establish that someone had stigma in that domain, you either reported strongly agree or agree with the statement. So a person who has experienced stigma was expected to strongly agree or agree in any of the 3 questions for that domain. So we had other variables with specific measures. For example, the social support score was measured using the 12-item MPSS, Likert scale, resilience score using the 2-item Conway-Davidson scale. And for independence in care, we had 2 questions. To assess independence in care, we asked 2 questions: attending clinic without a caregiver. Do you attend clinic without a caregiver? Or do you take medication without reminders from a caregiver? So those who said that they don't need caregiver support in either attending clinic or taking their medication were considered fully independent. Those who needed caregiver support in the 2 were considered not independent. And then those who required caregiver support in either one of them were considered partially independent. Depressive symptoms were assessed using the 9-item patient health questionnaire. And each question is scored on a scale of 0 to 3 with a possible total score of 27. We had some categorization. If you got a score of 0 to 4, then we considered you not having any depressive symptoms. 5 to 9 were mild, more than 10, 10 or more, were considered moderate to severe depressive symptoms. We also had a binary variable which classified the youth into having no depressive symptoms or having some depressive symptoms. We also assessed experience of violence, and we used the 3-item WHO violence against women instrument, assessing physical violence, sexual violence, emotional violence. And just to note that we adapted this questionnaire to also have gender neutral language so that even the young men could answer questions. So talking about the Ait regimen, we classified the Ait regimen into dolutegravir-based, the DTG-based. If your backbone had DTG, then you're considered DTG-based. NNRTI-based if you're on nevirapine or efavirenz. PI-based if you're on lopinavir or atazanavir, and other if you are not in any of the 3 categories. Then we also defined Ait adherence. We asked the question, number of days missed a dose in the last 30 days. So if you missed 1 or no days, then you are considered adequately adherent, more than 95%. If you missed 2 or more days of your doses, then you are considered to have poor adherence. Then viral suppression. So we collected, viral load data for the adolescents from the period when they, they completed their enrollment survey. And so we selected the first viral load done 0 to 12 months after they completed the enrollment survey. And we defined suppression to less than 50 copies per mil. So we understand that suppression in normal lingua in the guidelines is less than 1,000, but I think we're all moving towards suppression to undetectable levels, and we were keen on highlighting that. So that was our definition of suppression. For our descriptive analysis, we will present counts and so on for social demographics, HIV-related characteristics, and the stigma outcomes, and HIV stigma and also the outcomes. We also did an analysis for predictors of HIV stigma, that is overall and with the specific stigma types. And we only included modifiable, institutional, interpersonal, and individual level factors, things that we can do something about. And here we use generalized linear models our outcome, the overall, stigma was assessed on a continuous scale. So we'll present as such. And so we reported mean differences and adjusted mean differences. And this is a little different from us reporting relative risks or prevalence ratios. And we adjusted for age and gender. And then due to the clustering that we expected from facilities, facilities have different practices. We had our confidence intervals and p-values computed from clustered standard errors. So this is the health stigma framework. And what we see on the right is exactly what we presented before, what Turan and team did with the hypothesis. And then we are now moving a little more proximally to the left, and that is looking at predictors of HIV stigma. And we've listed as many as we could think about, and we are going to assess some of them in this study. So the next analysis was with to do the effect of HIV stigma. Again, we looked at the effect of overall HIV stigma and of the specific domains, kind of mirroring what is in the health stigma and discrimination framework. So we looked at the effect of HIV stigma on poor adherence, depressive symptoms, and viral suppression. So here we use generalized estimating equations since we were using longitudinal data. And we had a lot of missing data to be upfront on that. Across visits, we had 3 visits. So starting with baseline, we had about 1,000, more than 1,000. In the second visit, we had just about 700 and so on. So for us to maximize on the longitudinal aspect of the data, we did imputation using mice methods, and we reported relative risks and adjusted relative risks, adjusting for age and gender. And for the viral suppression model, we also adjusted for Ait regimen. So our study population, majority of our population was actually between 15 and 19. Only 41% were 20-24. Majority were female, reported female gender. And majority, again, were in school. About 22% had dropped out of school. And this is important because it comes out as an important factor. While 78% had either completed secondary school or were still in school, 22% had dropped out of either primary school or secondary school. And those who were in boarding school were about 27%. 59% received their care in either an adolescent or pediatric clinic or pediatric day. And only about 31% were in general or adult clinics, and about 10% were in the were pregnant or parenting, adolescents and youth, and so were in the maternal and child health clinic, what we call the PMTCT clinics. We estimate that 58% acquired HIV vertically, and only 40% were in a peer support group. And this is a highlight because Dr. Winnie did mention the impact of support groups. So we did see quite a lot of physical violence. 27% had ever experienced physical violence, with 13% reporting it in the last 6 months. 10% also experienced some emotional violence, abuse in the last 6 months, and 7% reported ever experiencing sexual violence, with 3% reporting it in the last 6 months. 64% of our population was sexually active. So looking at the prevalence, so let's first talk about the continuous measures. Out of in a range of 10 to 50, the overall mean stigma score was 25. And on a scale of 3 to 15, experienced stigma had a mean of 7. Again, 3 to 15, the internalized stigma had a mean of 6. Perceived stigma on a scale of 2 to 10 had 5, and the anticipated stigma, again, 2 to 10 had 7. Just noting that anticipated stigma was very high. And on the right, you'll see the bar graph showing the differences in prevalence. What you have on the extreme left is the overall, and then you'll see some subtle differences in age. The younger age group, 15 to 19, had lower stigma scores compared to the 20 to 24. And the female also reported higher stigma scores than the male. When you look at the co-occurrence, basically we are reporting column percentages. We see that there was very high co-occurrence of the different stigma mechanisms. And the lowest you can see on the extreme right, second row, that those who had anticipated stigma, only 25% reported internalized stigma. That was actually our lowest, with our highest being that 97% of those who reported some experienced stigma also reported anticipated stigma in the future. So the predictors of HIV stigma, what did we see as significant? When you compare those youth who had dropped out of school, comparing them to those who are still in school or completed, they had higher stigma scores. We also saw higher stigma scores among those who attended the general adult clinic. When you compare them to the adolescent clinic, we did not see the same significant effect for those who are in PMTCT, though our estimate is still on the higher side. Those who are in a support group had significantly lower overall stigma scores, while those who had partial independence, and this was counterintuitive, those who had partial independence had reported lower stigma scores compared to those who had full independence. Those who were in a sexual relationship, whether before or currently in a sexual relationship, reported higher stigma scores. Those who had self-disclosed to a partner, a sexual partner, their HIV status, they also reported higher stigma scores. And finally, those who had a previous violence or even recent, in the last 6 months, episode of violence, either physical, emotional, or sexual, reported higher stigma scores. And this is a busy table and not very keen on presenting everything here. This is basically the disaggregation across the stigma domains, the stigma types. And what we are seeing basically is the experienced stigma. Those who reported higher experienced stigma were those who were in sexual relationships, those who had self-disclosed, and those who had ever experienced violence. So there's, while we cannot say that there was, there's a causal effect, because this is a cross-sectional analysis, there is at least co-occurrence of these two items. So either the factor and the HIV stigma co-occurred. For internalized stigma, we are seeing higher scores for those who are dropped out, those who are receiving care in general adult clinics or in the PMTCT clinics, and lower scores for those who are in a support group, lower scores for those who are independent in care, and of course, we saw higher scores for those who experienced violence. Perceived community stigma was higher for those who had dropped out of school, was higher, lower for those who were in a support group, and higher for those who had experienced violence. And for anticipated stigma, being in a sexual relationship and experiencing violence predicted HIV stigma, higher HIV stigma. So what are the take-home messages for this analysis? This study identified modifiable factors, and those are the ones that we listed, proximal to HIV stigma. They either cause HIV stigma or they co-occur, and so are important to us. We saw violence as a highlight, sexual relationships, and thinking about the school environment or school enrollment and caregiver involvement in care, and also being in a support group, and also the clinic type influencing especially internalization of HIV stigma. So what's the importance of this information? These factors could be considered among other structural factors that are in literature when we are thinking of developing anti-stigma interventions. Think about how to address stigma in the school.
how to address stigma in sexual relationships, how to address stigma, how to address violence for those who are reported stigma, and so on. So these are important factors. So now thinking about the third question, what is the effect of HIV stigma? We had the outcomes. So important outcomes. One was viral suppression. And as I mentioned, we only picked one viral load. That was the first viral load after someone completed their enrollment survey. And that is what I'm going to report here. We had viral loads for 662 participants, and 46% reported non-suppression to undetectable levels. When we are thinking about suppression with a cutoff of 1,000, it was quite impressive. It was actually above 90% for this population. Also to note were the antiretroviral regimen. The guidelines now want us to move towards DTG, and I think we've done quite a bit of that in 2021 and 2022. But as at 2020, when we did this study, only about 24% had switched to the DTG-based regimen. So these are the longitudinal measures that we had. We have the stigma measures at the top across the 3 visits, and then we also have adherence and depressive symptom measures across the 3 visits. And you can see from the N columns that we had quite a large number of missingness, and we had this variation across the visits or when you're talking about either the prevalence of poor adherence. We're talking about 21% in the first visit, then we move to 10% in the second visit, and 8% in the third visit. So the reason why it was important for us to do the longitudinal analysis rather than just the cross-sectional was because we needed to factor this variation in the measures. So with the longitudinal analysis, what did we find? Overall stigma was associated with the 3 outcomes, and there were strong relationships. We can see from the very top, the bottom purple line, we can see the dot is just past 1.3 for overall stigma association with depressive symptoms. It's between 1.1 and 1.2 for its association with treatment adherence, and 1.2 for the association with viral suppression. And so this analysis does give us strong evidence that HIV stigma does impact mental health. It impacts health behaviors. Here we are assessing treatment adherence, and also affects the ultimate outcome when you're talking about health behavior for HIV, for adolescents living with HIV, and that is viral suppression. So when we are looking at the specific domains, experienced stigma was associated with depressive symptoms, again, treatment adherence, and viral suppression. Internalized stigma was associated only with depressive symptoms. Anticipated stigma was associated with viral suppression. Perceived community stigma was associated with depressive symptoms and viral suppression, as you can see from our forest plot. So thinking about the health stigma and discrimination framework once more, what we have at the top was what was hypothesized and what we have in literature currently. These are the relationships that we see. We were looking at the 2 middle boxes on our right. That is the affective, cognitive, and mental health. That is the depressive symptoms in our case, and also looking at healthcare behaviors, which we have antiretroviral treatment adherence, and the ultimate one is viral suppression. And we basically confirmed what was hypothesized in this framework. What we see, experienced stigma, that is the bold lines, affecting both depressive symptoms and healthcare behaviors. Perceived community stigmas, again, doing both. Internalized stigma affecting depressive symptoms. Anticipated stigma affecting healthcare behaviors. So what are the takeaway messages? The study confirmed, again, the hypothesis in the HIV stigma framework. The outcomes, which we know have very strong relationships themselves. We know depression has a strong relationship with adherence, And adherence also has a very strong relationship with the viral load suppression. And this we saw they are strongly impacted by HIV stigma. Addressing HIV stigma, therefore, may be key in achieving these individual treatment outcomes and the program targets. Many, many thanks to the DISC team. I have, all manner of pictures, but these are the ones that I found space for. The team's doing various trainings and preparing for this study and the follow-up study that came, that is ongoing. We also want to thank the DISC study participants, the clinic staff in the 9 clinics, now 20 clinics, and also the study staff who collected the data, the investigators, the study coordinators, Jacinta and James, and also, this work is part of my PhD work, also to include Dr. Manasi Kumar, who has given some very useful feedback, and our funders, the National Institutes of Health. Thank you very much. I'll push this back to Winnie. Thank you.
Thank you. Thank you very much, Dr. Mugo, for that quite insightful presentation on the DISC study. And really thanking the study team for bringing us such results. And I really agree with you that addressing HIV stigma is very key in achieving individual treatment outcomes and program targets. And you have really clearly demonstrated it. So this is very informative, and we would use this information just to see how else we can be able to modify our interventions either at national facility or county level to improve outcomes by addressing stigma. So without much ado, we'd go to the discussion section, and I would like to request if any of you has any question that you'd want to ask the panelists, that you can raise your hand to be allowed to ask a question, and also put your question in the chat for us to be able to address your questions. Looking at the chat, I can see appreciation for the informative session that we've had. A question here that is asking about seeing that self-disclosure is related to HIV-related stigma. How then can we improve disclosure support services to make sure we build capacity to deal with stigma? And how do you explain increases in HIV stigma in those in sexual relationships? Among youth and other factors affecting, here we are talking about stigma. Is there a role of integrating these services into other routine clinics? So probably some of the clinics that you did the study in, were they all standalone or some were integrated? So those are some of the questions that have been put in the chat. We can be able to answer that as we await to get further questions. Dr. Mugo, over to you.
Thank you so much, Winnie. And I'm very happy for these questions. So I'll tackle the first one. They're very related. So we are seeing an increase in stigma, especially experienced stigma among those in sexual relationships. At least there's co-occurrence in this. And this was not very surprising to us. Sexual relationships, the place where we have seen in literature a lot of cases of what we call inadvertent disclosure. You don't necessarily want to disclose, but it comes a time when you have to do that disclosure, and it does not always go well when you do that disclosure. It's not a case of when you do a disclosure, you benefit from it. And right now we're having a lot of literature that has come up that tells us as healthcare workers to be very careful with the advice that disclosure is the thing to do. It's not always the thing to do. It could increase violence. It could increase, it could make the relationship poorer than it was before the disclosure. And it's very nuanced. And so what we need to do is actually take the adolescent through, if we can, through the options that they've got. Is the disclosure necessary? How can we prepare them for positive feedback, in a case where the person whom they've disclosed to accepts them, or in cases where they've not been accepted, also prepare them for the same, and also have these support groups that they can benefit from. And also identify areas where self-disclosure may actually be harmful. And that is, we'll have the red flags. Are you in a relationship that is violent? That is not one where you want to be discussing self-disclosure, especially for the young adolescents and the young people. So we've had many recommendations, especially on disclosure. Many of them were targeting, were in the continuum of self-disclosure will help with reducing incidence of HIV, because when you self-disclose, there are higher chances of condom use or no sex at all. But with the messaging that we now have of you equal to you, we have to start now rethinking the messages about self-disclosure and being very, very targeted, especially with young people on whom they tell their HIV status, and actually identifying that it actually benefits them when they do that disclosure. I don't know whether that is satisfactory for the question on self-disclosure and sexual relationships. That's my take on it. And happy to hear what they think too about that.
Yes, thank you. Probably we can hear more of the question if at all it wasn't clarified. However, you really highlighted the issue of to avoid such, then we need to have assisted disclosure so that we can be able to have a controlled environment where disclosure will happen, and we are able to anticipate for whatever will happen in terms of mitigating violence and the negative effects of having disclosed, especially to a sexual partner. So thank you for that. I would want to also bring another question from Emmanuel is asking if there's a relationship between suicide and stigma in the study. Really asking if there's any data on suicidal ideation and the level of stigma, maybe in terms of depression, and what percentage or proportion are considered to probably be suicidal or even have committed suicide. There's another question here, really looking at an issue of an adolescent 17 years old who has been fully disclosed but still not virally suppressed. So could this stigma be part of the problem, or what could be other problems? And then Vincent is asking if stigma also is a determinant or a factor that will affect participation in the study. Could we have had dropouts because of stigma-related reasons? And maybe we can answer those before we move to the next questions, Dr. Ari.
Thanks so much.
Yes.
Yes, thanks for those questions. And let's start with stigma and suicide. So we did not have an assessment of suicide for our population. But I think I'll take that because the PHQ-9 does assess suicidal ideation as one of the questions. And that's something we can actually look at, suicidal ideation. So we may not, studies may not be very well powered to look at suicide. It's a very rare outcome, especially among adolescents living with HIV. But we do have a lot of evidence, and this has been built by many researchers, including here in Kenya. For example, Dr. David Bukusi is doing a lot of work on suicide. And we do see a big relationship with HIV, stigma and the mental health aspects that would be, may lead to suicide and or suicidal thoughts, at least with outcomes framed as such, suicidal thoughts, suicidal ideations. We have seen at least HIV testing being linked to it. But that's one thing that we can actually look at, just the one question on suicidal ideation, and we can report on that. Thanks for that. So the next question is about full disclosure. Could, even after fully disclosing to someone, an adolescent, them not achieving viral suppression? Yes, stigma is one of the biggest reasons. And you're talking about a 15-year-old. And we've seen several things in this study. One is the school environment. We've got to think about, despite disclosing, telling them that they're HIV infected, that's fine. That has been shown to improve adherence. The literature is not very clear on that. You've got to do the correct process. And identifying that the correct process, I know, is challenging, but with the correct process taken, an adolescent taken through a rigorous disclosure process, then we expect, and literature, bears us that we should expect improved viral suppression. There are cases where we are now seeing early disclosure of HIV status that is not reinforced in early adolescence, leading to poor outcomes in mid-adolescence. And so we are talking about 14, 15, 16-year-old suddenly getting poorer adherence, poorer viral suppression at that age group, because while the disclosure was done as a 10, 11, 12-year-old, there was no reinforcement with improved literacy and literacy that would help them gain some independence to getting into that age group. And what we see is them realizing what being HIV infected means in mid-adolescence, and that causes a further slump in they're taking their medication and, of course, viral suppression. But we cannot forget that we are also dealing with many adolescents who were vertically infected. They acquired HIV in childhood and have been on treatment for a long time, have been through several regimens, and may be having, some of those regimens may not be as effective right now. There could be some, viral mutations causing some resistance. And that is where switching them to dolutegravir comes in. I know the program, HIV program is on high gear to ensure that everyone is on dolutegravir, which has much better outcomes. So there are many factors, but HIV stigma definitely plays a role. Could stigma have played a big role in recruitment? Yes. And that's one of the weaknesses of many of our research studies, that we do see us excluding our population, especially the population that does not come to clinic, because we enroll most of our population in the clinics. And so those who may have been lost to care, those who feel that they do not want to do anything extra in the clinic because they feel a little longer stay in the clinic is injurious to them, then they will not participate in the studies. But this does something, it basically does reinforce. This missingness does reinforce our message, because these are the people who have these poor outcomes. And while we could say that it does impact the study, it impacts them in a way that our study results would be reinforced in case they were included. Those were the 3 questions.
Thank you, Dr. We have more questions in the Q&A section. The first one is talking about parenthood. So as you are looking at the different factors affecting stigma, you talked about it was lower among those who had partial independence. Could this be those who still have a caregiver supporting them? And then here the question is looking at single parenthood and the input of parenting in reducing stigma. And then a question that probably we can have also answered by the larger team is the best age to start disclosure. The other question is looking at internalized stigma, because we are seeing that we have several youth who have internalized stigma. So how are we able to what can be done, especially looking at internalized stigma, and what are the factors that are contributing to internalized stigma, so that maybe at the level of psychosocial support groups and also dealing with caregivers, we can be able to try and address them. There are other questions on disclosure to a sexual partner. And a question on what we have done. I think this we can talk about. I can answer that on what we have done in schools. And I think we can handle those for now.
Okay. So let me handle the question on parenting and stigma. Just taking us back a little to the findings. What we found was, pretty interesting. We expected something different. So we did not expect, what you'll see from this is, so what you'll see on the left column, so what you're looking for in this forest plot is, on the left column, you're looking for full independence, the two full independence, rows, and on the right, you'll see partial independence. So our predictor is partial independence compared to full independence. Our main difference was on the negative side, meaning that those who had partial independence basically had lower stigma levels. This was counterintuitive until we did, I talked to several people who are dealing with children and adolescents in very different, answering very, very different questions. So the superarching question is, what is the role of a caregiver in the HIV care for youth? People who are a little older, they're 15, they're 20, they're 24. What is the role of the caregiver? So when a caregiver is involved, do they enhance that care or they contribute to derailing of that care? And this is a question I'm not able to answer with this study, but what we've seen consistently with studies that have been very, very specific with that question is that the caregiver enhances care. So involvement of the caregiver in some way improves the outcome, treatment outcomes for that adolescent. The adolescent needs to be independent. Therefore, they need to start taking their medications. They need to go to their clinics without the caregiver necessarily, having to accompany them. But in cases where we have seen the caregivers involved, what this study is telling us is that we can expect better outcomes for those adolescents and youth. And so for those of us who've got young people in our families and you're their caregivers, it's a plus if you get involved in their care. It's a plus if you get involved with coming to clinic with them. That's what we can take from that. Age of disclosure, the guidelines tell us we start partial disclosure from age of 6. And we have developed many tools. We have had many interventions, especially in Kenya. Some have informed the guidelines that we have currently in the world. And the age of 6 is debatable. People, say earlier disclosure, you start early, that's good. But the child will not necessarily understand everything when they're young. So this process has to go on for about 10 years. You've got to start at 6 and you'll take it all the way to age 15, 16. And that is how you are going to impact them positively. And you'll be talking about different things in the different ages, and the tools and the interventions have shown us these things. So again, what contributes to the internalization of stigma for us? The factors that co-occurred or influenced internalized stigma were generally school enrollment. Being out of school is one of the big, having dropped out, not just being out, but having dropped out of school was a big factor. The other one was being taken care of, healthcare setting. Where are you receiving your care? Are you receiving it in the adolescent clinic, or are you receiving it in the general clinic? Someone had asked whether we had these, combined clinics, and yes, when we say general or adult clinics, some of them were specifically adult, and the general clinic was where we have combined populations. So if you have your adolescents and youth in the general or adult clinics, we have them, we have higher stigma levels among those youth. And one of the reasons why we saw this happening was actually because of the next factor, which was availability of peer support groups. Those who are in the adolescent clinics, a big proportion of them had access to support groups. Those in adult clinics did not. And that was one major difference. The adolescent clinic provider has been trained on how to offer adolescent-friendly services. This has been going on for about 10 years with the adolescent package of care. So we can expect that there'll be a difference with how they handle our adolescents and youth. And lastly, the independence question that we've just discussed. And of course, violence was also the other point. And the question on what the program has to do, I think I can leave that to you, Winnie.
Yes, thank you. Thank you for the responses so far. So looking at what the program has done in schools, the national program has done a lot to ensure that we are able to address stigma in schools. And the main thing that has been done is to have improved treatment literacy among the teachers and those who take care of children in schools, just ensuring that they've been trained and they have knowledge on HIV management and what HIV is all about. The other thing that we talked about was the HIV curriculum that is being taught in schools. However, we noted in the beginning that this curriculum needs updating, and so we'll be working with the Ministry of Education to ensure that the curriculum is updated and has up-to-date information when it comes to HIV. The other thing that we have also done, and even the Ministry of Education has done, they have the network of teachers who are living with HIV, who are really supportive, especially in schools, in boarding schools. They are treatment supporters for adolescents who are in boarding schools, and they help these adolescents in adherence and just ensuring that we have daily witnessed injections, especially for adolescents who are having challenges taking their treatment and have adherence issues. So we have several interventions within the school, and also just improving the linkage between the facility and the schools, especially in areas where we have a number of adolescents who are going to those schools and they are on treatment. We also have adolescent champions that are part of the students in the schools who work to ensure that they continue with the provision of peer-led psychosocial support while they are in school. So these are some of the interventions that have been done in conjunction and in collaboration with our partners in several counties. So we have seen them to work. However, we've not been able to have them implemented in the whole country. So we would want to see that scaled up to other counties so that we can be able to reap the benefits of just being able to work with schools to ensure that these youth who are in school and spend most of their time in school are well taken care of, and we don't have situations where when they close school and come to the facility, that's when you notice that they are having gaps in their treatment. So I hope that question has been answered. We can go to the hands that have been raised so that we can also give them a chance to voice their questions and concerns. We'll start with Eliud Sirengo. Please, you can unmute yourself and ask your question. Eliud Sirengo.
1 minute to unmute him.
Okay.
Just also look for the other hands.
We also have Mahat Mohammed, Doreen Kendi, Francis Mwangi, and Odongo. If Eliud Sirengo is having a challenge unmuting himself, we could go to Odongo has unmuted. You can go ahead and ask your question.
Thank you very much. That was a very, very enlightening presentation. And it is really informing us of a number of issues that we really need to know about HIV and stigma. I work a lot with the young people and especially the adolescents. And my question would be, these adolescents, when they get into their sexual life, they tend to sometimes hide a number of things. I just wanted to know the legal standing in disclosure. Can somebody take a partner to court or for legal redress if they did not disclose their status and yet they knew they're HIV positive?
Thank you, Odongo.
Winnie, I don't know that you want to take another one or you want to first address that?
We since we are having a bit of a challenge unmuting, I don't know if while we ask Eliud or Mahat to unmute, you can be taking that question.
Oh, okay, I wanted to actually defer this to you. So I think the legal point, so there is the question of disclosure of HIV status when it comes to putting someone at risk. And I'm not very sure of the complete wording for this. And I could say that one of the reasons why I have a challenge with this is in many, many cases, we are looking at placing a responsibility on a person. So I talked some previously on power dynamics. So you have on one hand a person living with HIV and then a person of unknown HIV status on the other. So or a person who considers themselves HIV negative. And then in many cases, we want to place the responsibility of protection on the person who is living with HIV. So there are questions about condom use, for example. Do we expect that this will be the decision and the initiative of the person living with HIV, or is it the person on the other side, or it should be a shared decision? So that is one that I hope, my hope is that this is the reasoning that could go around this question, even as we look at the letter in texts of the law. The next question is, apart from the power dynamics, next question is for a person who has an undetectable viral load. This person there's no risk. We know now that there's no risk of transmission of the virus. And so should they still bear the responsibility of having to disclose their HIV status? So that is the next question that we need to think about when we're talking about now the structural aspects of HIV stigma. I've not answered your question on what the letter of the law is, but I would just like to drive the question or the thinking around disclosure of HIV status in those two ways.
Thank you. That would be a question that I would need further, especially legal input in terms of whether we can clearly say it is illegal or the nitty-gritties. However, we know that as Dr. Mugo says, that it is the responsibility of every individual to know their HIV status and to take the necessary precautions not to transmit the virus to unwillingly or knowingly to someone who does not have HIV. So when it comes to the law and just getting to know if this person did not have HIV and the transmission happened because of this interaction, that I probably would not be able to articulate it. However, just to mention that it is what we need to spread is the knowledge and information that it is every individual's responsibility to know their HIV status. And if they know their HIV status, then it is also their responsibility to ensure that they don't transmit it to anyone. So we can move on to the next person to ask the question. If we can give it to Mahat. Mahat, you are unmuted. Can go ahead and ask the question. Is Doreen Kendi still there? She can ask her question. I'm not sure if her hand is still up. We have John Juguna, who has just raised his hand up.
Good evening. My question was maybe following up on what Songa talked of. The question on deliberate transmission of HIV and STI, especially when you transmit to your partner and maybe you did not discuss about your status. How does the law take that?
Thank you.
Yeah, just a little follow-up. You know, Kenya is, the law is a little more liberal on the question of disclosure to sexual partners. Unlike many states in the US and Canada that have express laws that would find you liable if you transmitted the virus. So in fact, in Canada, it's much stricter. You know, if you do not disclose your HIV status to your HIV partner, to your sexual partner. So in Kenya, I have not had cases where, you know, we've had questions of deliberate, which I think would be very difficult to prove that you deliberately infected somebody. And that is a very challenging exercise to actually set out to infect somebody. We know the chances of, you know, transmitting HIV are pretty low. So that would have to be a pretty, you know, daunting exercise to take. But for Kenya, I've not had such cases. There are jurisdictions, as I've mentioned, that have very explicit laws that require disclosure. And people are fighting these laws because they are very discriminatory. First of all, you're talking about a balance of power, because in many cases, it's a discussion of condom use. You know, that is the discussion. The question is of condom use. So who in the relationship makes the decision on condom use? And is the person who is living with HIV in many relationships, are they the ones with the power to determine condom use? So if you break down a lot of this discussion, it boils down to that one question. And the reason why there's a big fight to get rid of these laws, these are what we call HIV discrimination laws, and they're the ones which are being fought. And in the US, we have had landmark cases that have thrown out such you know, previous judgments that were given against people living with HIV. And this is the light at the end of the tunnel that we can see. Yeah, so but the exact legal wording that we have in Kenya is something that we would have to check.
Thank you. Thank you for that. We have a panelist who has raised their hand up. Prof. Omu Anzala, please.
Yeah, thank you. And let me thank, I came in a bit late, but let me thank, you know, colleagues who are actually doing very, very wonderful work. And the issues you are actually discussing are some of the issues that we are grappling with. I just want to know from any of the panelists, we are interested here at CAVI at beginning to look at immunology, but more so mucosal immunology in adolescent, but maybe not adolescent. We want to start at the age of 12. And as we talk about that, we want to look at, as we look at viral load in the peripheral, we are interested in also looking at viral load in the mucosal, you know, surfaces, maybe looking at vaginal secretions as well as cervical secretions. So is this doable? And in terms of ethics and acceptance, in terms of collecting this kind of samples, is this doable so that we can be able to understand issues to do with the suppression, not just in blood, but also suppression at the site where, you know, the virus really infects? Because we have been able to collect cervical secretions in adults, we've been able to look at semen to actually measure, you know, viral load in those who are suppressed and those who are not suppressed. but we want to take this now to lower age groups beginning 12. So could I just hear from you guys, how do I present this to the ethics so that I can be allowed to be able to collect this kind of samples at that age group? Over to you.
Oh, Prof. I think Winnie, I can hazard.
Please go ahead.
Yeah, thanks, Prof. And this is such exciting research. There are two things I can think about. One, we have what we feel as a scientific community is unequivocal evidence that unsuppressed viral load leads to no transmission of the virus. The mechanism for that must have something to do with the mucosal viral load. And I would imagine that is the evidence that we need, basically, to say that when we've got your serum viral load, it correlates very well with either your whatever mucosal surfaces you're talking about, rectal, vaginal, or so on. And I think that is one of course, the missing pieces of literature that we don't have for the adolescents and the youth. So that's the big one I could have. The other one I think would be just scientific curiosity, which of course ethics would have a big issue with. But I don't know whether you feel, Prof, that would be a good enough argument to propose.
No. You see, what I've learned over time, Doc, is that really we must listen and we must ask, those hard questions. And I come from, the school of thought also that, viral load is dynamic, and little things influence the movement. And also what we have seen is compartments may sometimes differ in viral load. So what we just want to be able to chart is to build a little bit more evidence on that. And also just understand at this young age, how does the things that most of you know now, we are talking about as a microbiome. How does also microbiome influence, all these things, so that we can add value. And then this will also influence when we begin to talk about vaginal rings and things that we are going to use locally at that site to try and prevent transmission, so that we can bring all these things to bear. So that is where I'm coming from, but I'm ready to listen. I'm ready to collaborate. If any one of you wants to get in touch, please do, because we are planning this study and we would like to ensure that we get approval to really go deep into the immunology. And at the same time, when we get a flicker and we can isolate the virus from the cervical, secretions or from semen, how does this virus compare with what could be seen in the peripheral circulation? Because also this has implications for us who are interested in vaccine development. So that's where I'm coming from. But this is excellent. This is the kind of information that we can use to enhance the proposal that we are putting together. Over to you.
Yeah, thanks so much. Yeah, and we'll definitely get in touch. We'll definitely get in touch with you. I don't know whether Winnie or Diana had any comments on that.
I would want to hear more about what that entails. Right now, I don't think I have an answer as to whether that would be approved, but in terms of just the study methodology and the objectives, then I'm sure if you had to look more at it, then we would be able to see how to make it mainly feasible, and also to see if the results would be able then to inform the interventions, especially for us as a program, as we look at having interventions also in the younger population of the adolescents. So for me, I would probably want to learn more before we are able to give a clear answer.
Yeah, and just reach out. We are not very far from where you are.
Yes.
Yeah, yeah, because we also want, collaboration. You have more experience with this age group than what we have, so there is much more, for us to, to learn, and you can guide us as to, the whole issue. And the idea here is really to learn young and adolescent immunology. Yeah. That is the whole point that can also inform adolescent vaccines. How do they work and how do we administer them? That's where we are coming from.
Yes, thank you. Thank you very much for that. And it would actually be very helpful for us to just be able to move forward and ensure that we're able to address the issues that are affecting the adolescents and youth. So I don't know if there's any other panelist who has a comment on the same issue as we move towards the end of the discussion. Okay, so as we wind up, I just had a question that I wanted to ask Dr. Mugo from the study. You noted that as the number of visits increased, the level of stigma kind of decreased, if I didn't get you wrong. What could have contributed to that? Because I know one thing that we talked about when it comes to stigma is that the more you talk about it, the less the stigma. And so in terms of the findings you had, what do you think could have contributed to the fact that there were levels of stigma, reduced levels of stigma as the number of visits increased in the study participants?
Yeah, thanks for that. So yeah, we did note that, in this little table here. And our suspicion, of course, is the dynamics of the data itself, a lot of missingness in the visits. So who was missing these visits is the question, is the interesting question that someone asked before. Who missed the visit 2, who missed the visit 3? Could it be the people who basically had more stigma? And that could be one of, I know we were moving into COVID, and the reason mostly was COVID, that they were not able to come to the clinics because of COVID. But to note, the stigma levels did not actually decrease. What we note from visit 1 overall stigma, we had a mean of 25, visit 2, 25, visit 3, 25. What we saw decreasing was actually the outcomes, 21% in visit 1 for poor adherence, 10% for visit 2, and 8% for visit 3. So the dynamics of this, of course, in statistics, of course, you've got to question whether this was missingness at random or completely at random or not at random. But this is a bigger discussion, of course, that we're having with biostatisticians. And our conclusion for now was that this was missingness at random. Could be related to the stigma level, but unlikely to be related to the outcome levels with the tests that we did. But you can't rule it out though. But stigma levels remained the same throughout the visits, 25.
All right, thanks for the clarification. Yes, so I'm not sure if we left anyone out. If at all there's a question that has not been addressed in the Q&A section, maybe you can allow you to unmute yourself and ask the question.
Yeah, you're just on time.
Okay, so as we wind up, I'd want to probably, if you have any closing remarks, Dr. Mugo and the rest of the panel.
For me, I think it's to say a big thank you to the big group that listened to us. And we hope that we can start now developing and helping our adolescents, developing interventions and helping our adolescents cope with HIV, live with HIV, not just cope and thrive with HIV. Thank you.
Thank you. Thank you very much for this session. It was very insightful and we had a very good attendance and participation from the team. we've been able to see from the study and the results that really we have modifiable factors that we can work on to help reduce stigma. And these have to do with issues to do with sexual relationships, school, and also issues of violence that really, as a program, we can also be able to look at and see how we can be able to address them in order to contribute to reducing stigma and achieving the objectives as envisioned in the Kenya AIDS Strategic Framework. So we really want to thank the team, and we want to see more of work done around adolescents and youth. Stigma is one of them, which has really little data, so this can really contribute to the body of knowledge when it comes to addressing stigma. We want to thank all the participants, all the panelists, and those who attended this session for this interactive session. Looking forward to more engagements in the other sessions going forward. So from my end and the rest of the team, I want to thank you all, wishing you a very good rest of the afternoon and evening. Thank you very much.
Thank you so much. Thank you.